Hello and welcome. Today we'll be exploring Gorlin syndrome, also known as nevoid basal cell carcinoma syndrome or NBCCS. This complex genetic disorder affects multiple systems in the body, and in this video, we'll delve into its various aspects, with a particular focus on its cardiac manifestations. Gorlin syndrome is caused by mutations in genes, most commonly the PTCH1 gene, which is located on chromosome 9q23. This gene plays a crucial role in the hedgehog signaling pathway, which is essential for normal development. Less commonly, mutations in the CUFU or PTC2 genes can also cause Gorlin syndrome. These mutations are typically inherited in an autosomal dominant pattern, meaning that only one copy of the mutated gene is needed to cause the disorder. However, in a significant number of cases, the mutation occurs spontaneously, meaning it's a new mutation in the individual and not inherited from their parents. The PTCH1 gene normally acts as a tumor suppressor. When functioning correctly, it inhibits the hedgehog signaling pathway. Mutations in PTCH1 disrupt this inhibitory function, leading to uncontrolled activation of the pathway. This excessive signaling promotes cell proliferation and abnormal development in various tissues, leading to the characteristic features of Gorlin syndrome, including the increased risk of basal cell carcinomas, odontogenic keratocysts in the jaw, and other skeletal and neurological abnormalities. When it comes to the heart, although not a primary feature, cardiac fibromas and valvular abnormalities can occur due to this disrupted signaling and abnormal tissue development. Gorlin syndrome is relatively rare, with estimates suggesting it affects approximately 1 in 30,000 to 1 in 40,000 individuals. It occurs in all ethnic groups and affects males and females equally. Because it is a genetic condition, diagnosis often occurs in childhood or adolescence, although milder cases may go undiagnosed until later in life. The actual prevalence might be underestimated due to the variable expression of the syndrome and the possibility of some individuals having milder or incomplete forms. The signs and symptoms of Gorlin syndrome are highly variable, even within the same family. The most common feature is the development of multiple basal cell carcinomas, often starting in adolescence or early adulthood. Other common features include odontogenic keratocysts in the jaw, which are benign but can cause swelling and pain, skeletal abnormalities such as bifid ribs, fused vertebrae, or scoliosis, and neurological manifestations like medulloblastoma, a type of brain tumor. Concerning the heart, some individuals with Gorlin syndrome may develop cardiac fibromas, which are benign tumors of the heart muscle. These can sometimes cause arrhythmias or obstruction of blood flow. Valvular abnormalities, although less common, can also occur. It's important to remember that not everyone with Gorlin syndrome will experience all of these features. Diagnosis of Gorlin syndrome is typically based on a combination of clinical findings and genetic testing. The diagnostic criteria, as established by Evans et al., and later modified, involve both major and minor criteria. Major criteria include the presence of multiple basal cell carcinomas, or one before the age of 30, odontogenic keratocysts, palmar or plantar pits, calcification of the falx cerebri, bifid or fused ribs, and a first-degree relative with Gorlin syndrome. Minor criteria include macrocephaly, congenital malformations such as cleft lip or palate, skeletal abnormalities like scoliosis or sprengeal deformity, and ovarian fibromas. The presence of 2 major criteria or 1 major and 2 minor criteria usually warrants suspicion for Gorlin syndrome and further investigation. Genetic testing specifically of the PTCH1 CUFU and PTCH2 genes can confirm the diagnosis. While Gorlin syndrome doesn't have distinct subtypes in the traditional sense, the presentation and severity of symptoms can vary significantly between individuals. This is often referred to as variable expressivity. Some individuals may have a mild form of the syndrome with only a few basal cell carcinomas and minor skeletal abnormalities, while others may have a more severe form with multiple tumors, significant skeletal deformities, and neurological complications. The presence and severity of cardiac fibromas or valvular abnormalities also vary considerably. Treatment and management of Gorlin syndrome focus on addressing the specific symptoms and complications that arise. Basal cell carcinomas are typically treated with surgical excision, Mohs micrographic surgery, or radiation therapy. Odontogenic keratocysts are usually surgically removed. Medulloblastomas are treated with a combination of surgery, radiation therapy, and chemotherapy. Cardiac fibromas, if causing significant symptoms, may require surgical removal or, in some cases, monitoring. Regular monitoring for the development of new basal cell carcinomas, odontogenic keratocysts, and other complications is essential. Genetic counseling is also important for individuals with Gorlin syndrome and their families to understand the risk of passing the condition on to future generations. Individuals with cardiac involvement should be monitored by a cardiologist. Currently, there is no known way to prevent the genetic mutation that causes Gorlin syndrome. However, early diagnosis and management can help prevent or minimize the complications associated with the condition. Regular skin checks, dental examinations, and neurological evaluations can help detect and treat problems early. Avoiding excessive sun exposure and using sunscreen can help reduce the risk of developing basal cell carcinomas. Genetic counseling can help families understand the inheritance pattern and assess the risk of recurrence in future pregnancies. The prognosis for individuals with Gorlin syndrome is generally good, although the condition is lifelong and requires ongoing management. The development of multiple basal cell carcinomas is a major concern, but with appropriate treatment, these tumors are usually curable. The presence of medulloblastoma can significantly impact prognosis, but advances in treatment have improved survival rates for this type of brain tumor. Cardiac fibromas, if present, can cause complications such as arrhythmias or obstruction of blood flow, but these can often be managed with medication or surgery. Recent research has focused on developing targeted therapies that specifically inhibit the hedgehog signaling pathway. Vismodegib and sonidegib are hedgehog pathway inhibitors approved for the treatment of advanced basal cell carcinomas. Research is ongoing to explore their potential use in managing other aspects of Gorlin syndrome and cardiac manifestations. Further research is also focusing on identifying new genes involved in Gorlin syndrome and understanding the mechanisms underlying the variable expressivity of the condition.